Welcome back to the deep dive. If you're staring down the barrel of the OBGYN and BME shelf exam, well, you've definitely come to the right place today.
Hmm.
We're tackling a cluster of really high yield topics that tend to show up, things like hyperprolactinemia and galactorrhea,
Right.
abnormal uterine bleeding, let's just call it AUB, pelvic pain, and then those two tricky ones, endometriosis and adenomyosis.
Exactly. And our mission here today isn't just, throwing definitions at you. It's about connecting the dots.
Yeah.
We want to pull out that critical information you absolutely need for the exam, but also for your future clinical work. Think of this as a shortcut, really, to the core concepts.
Getting the essence without drowning in the details. Love it.
Okay.
Okay, let's dive right in then. Hyperprolactinemia and galactorrhea.
Okay.
So hyperprolactinemia, simply put, elevated prolactin levels. And galactorrhea is that milky nipple discharge, but not related to pregnancy or breastfeeding.
Correct. And prolactin, PRL, it's made in the anterior pituitary. Its main jobs are, breast development and milk production.
It's all about balance, though, isn't it?
It really is. TRH, thyroid-releasing hormone, and serotonin tend to stimulate its release. But the main brake, the primary inhibitor, is dopamine.
So when that balance gets thrown off and prolactin levels shoot up, what happens downstream? We see things like irregular periods or no periods at all, amenorrhea, oligomenorrhea,
Right, problems with ovulation.
and the galactorrhea itself. It's all because that high prolactin messes with GnRH release. Is that right?
Precisely. That elevated prolactin suppresses the normal pulsatile release of GnRH.
Okay.
And that just disrupts the whole hormonal cascade you need for regular cycles and ovulation. Now, why does prolactin go up? The reasons are, well, pretty varied.
They really are. Medications seem like a huge category.
Oh, definitely. Antipsychotics are often, the most cited culprits.
Yeah.
But you've also got antidepressants, some of the older TCAs, SSRIs, certain blood pressure meds like verapamil, methyldopa, even opioids, anti-nausea meds like metoclopramide.
And worth remembering, oral contraceptives, OCPs, can sometimes nudge levels up a bit too.
That's a key point for exams, absolutely.
Mm-hmm.
Different drugs interfere with dopamine in various ways, leading to higher prolactin. Then there's hypothyroidism.
Ah, right. Low thyroid hormone.
Low T4 means the body ramps up TRH production, trying to stimulate the thyroid.
And that extra TRH also stimulates prolactin. Got it.
Then you have issues potentially in the hypothalamus itself, certain tumors, inflammatory conditions like sarcoidosis. They can mess with dopamine, getting down to the pituitary.
And then the pituitary gland itself, prolactinomas are the big one there.
Exactly. Benign tumors secreting prolactin. We call them microadenomas if they're less than a centimeter.
And macroadenomas if they're bigger.
Right. You can also see things like lactotrough hyperplasia, just an overgrowth of those prolactin cells, or even conditions like empty cellus syndrome or acromegaly sometimes associated with it.
And don't forget systemic stuff. Kidney disease affects clearance.
Good point.
Chest wall surgery or trauma can trigger it. And even like normal physiological things, breast stimulation, exercise, stress, sleep, eating.
And stress is actually a really common cause of mild elevations. That's important to keep in mind.
Okay, here's a really crucial distinction, especially for exams. Medications are super common causes of galactorrhea and hyperprolactinemia, yes, but they do not cause pituitary adenomas. Those just arise on their own.
Absolutely correct. Critical point. Now, focusing on prolactinomas specifically, like we said, tumors secreting prolactin, most common pituitary adenoma causing this.
And they're not actually that rare. Some estimates suggest maybe 10% of people might have an incidental pituitary adenoma.
Right.
And if a woman presents with hypoprolactinemia, the chance she has a prolactinoma jumps way up like 50%. And if the PRL is super high, over 200 ng/ml, it's almost guaranteed.
Yes, and the vast majority are microadenomas. The good news, most don't really grow much over time.
That's reassuring.
So hyperprolactinemia, even with a small microadenoma, is often benign. Treatment might not even be needed unless, say, estrogen levels are low or the woman wants to conceive.
It's also good to know that pregnancy, OCPs, hormone replacement, they generally don't make these microadenomas grow. That's a common patient concern.
Definitely. Clinically, patients might present with those menstrual issues we talked about, galactorrhea, maybe headaches.
And if it's a macroadenoma,
If it's a larger one, it can press on the optic chiasm. That gives you that classic bitemporal visual field defect, losing the outer peripheral vision.
so exam-wise, breast exam is key. And if you suspect a macroadenoma, you need formal visual field testing. What about key lab tests or imaging?
First step, always a serum prolactin level.
Mm.
Then you need TSH, free T3, free T4, to rule out hypothyroidism.
Right.
And for imaging, the best look at the pituitary for masses or empty sella is an MRI of the brain with contrast. Nothing beats it for sensitivity.
And management. Seems like step one is always look for culprit drugs, snipe them if you can, recheck the prolactin.
Exactly. If you can't stop the drug and the prolactin is still high, maybe over 100, then you'd move to imaging.
What if someone just has galactorrhea, but periods are normal, prolactin's normal, TSH is normal?
Often, no therapy is needed in that case.
Yeah.
But if treatment is required, say for infertility or bothersome symptoms, cabergoline is usually first line.
Cabergoline, that's a long-acting dopamine agonist. Lots of advantages, right? It can actually shrink macrodenomas,
Yes, significant tumor reduction is possible.
helps restore ovulation for fertility, stops the galactorrhea, and generally better tolerated, only taken once or twice a week.
Correct. Good side effect profile, convenient dosing. And crucially, for pregnancy attempts, you stop it once conception is confirmed.
Bromocriptine is the other one. Second line.
Yes, also a dopamine agonist, but often more side effects, nausea, dizziness, and needs twice daily dosing. Surgery, the transsphenoidal approach, is really reserved for when medical therapy fails or isn't tolerated and symptoms persist.
And surgery has risks diabetes insipidus, hypopituitarism. Cure rates aren't perfect, especially for macrodenomas, and they can recur.
True. Radiation is sometimes an add-on for large tumors that weren't fully removed. And because of the potential for low estrogen long-term, you need to think about bone health osteoporosis prevention or treatment.
Okay, high-yield exam takeaways, MRI for diagnosis, cabergoline for conception with microdenomas, prolactin often drops during pregnancy, and importantly, no increased birth defect risk with these drugs used for fertility.
Good summary. And a quick ward tip. Patients generally find cabergoline easier to take and more effective than bromocriptine.
Zebra alert.
Very high-dose cabergoline for Parkinson's has been linked to heart valve issues, but that's not seen at the lower doses we use for hyperprolactinemia.
Yeah.
And confirming galactorrhea. Just look for fat droplets under the microscope. Simple.
Right, let's transition to abnormal uterine bleeding AUB. So this is basically any uterine bleeding that's off in terms of volume, duration, regularity, or frequency for reproductive aged patients.
Right. And the Palm-Cohen classification system is incredibly helpful here. It's the standard FIGO-COG system.
PALM for structural causes, polyp, adenomyosis, leiomyoma, fibroids, malignancy hyperplasia.
And COEIN for non-structural. Coagulopathy, ovulatory dysfunction, endometrial causes, iatrogenic, like medications or IUDs, not yet classified. It really helps organize your thinking.
Super useful framework. So in reproductive aged women, most AUB comes down to pregnancy issues, structural problems, ovulation issues, bleeding disorders, or neoplasia, right?
That covers the vast majority, yes. Sometimes trauma or infection, too.
Thinking about those structural or organic causes, we're talking reproductive tract diseases, pregnancy complications like miscarriage,
Malignancies, endometrial, cervical, even those rare estrogen-producing ovarian tumors.
infections like endometritis, STIs, structural things like fibroids, polyps, adenomyosis, foreign bodies, vaginal trauma.
Then there are systemic causes, bleeding disorders like von Willebrand's,
Right.
other clotting factor issues, leukemia, sepsis, ITP, thyroid problems, both hypo and hyperliver.
And iatrogenic things we cause, anticoagulants, hormonal contraception, hormone therapy, even some psychiatric meds.
And then we get to the ovulatory versus anovulatory causes. Ovulatory AUB is more about issues with endometrial blood vessel control, maybe clotting locally.
But anovulatory bleeding, that's a big one for the exam.
Absolutely. This is key. It's continuous estrogen exposure without the balancing effect of progesterone.
So the lining just builds up.
It builds and builds, gets unstable, and then sheds irregularly, often heavily. You see this classically in PCOS, obesity, adolescents just starting their periods, perimenopausal women.
And that mechanism is important. The constant estrogen causes proliferation, but without progesterone, there's no organized maturation and shedding. It gets thick, disorganized, sheds unpredictably, and that unopposed estrogen over time raises the risk of hyperplasia too.
Exactly. So when you're taking a history for AUB, you need the details. Precise menstrual history, LMP, any changes, frequency, duration, bleeding between periods, bleeding after sex.
And trying to quantify it is key, even though it's hard. Pads tampons per day, soaking through, clots, flooding, changing overnight.
Yes, and asking, is this new or has it been happening since menarche? Any associated symptoms, pain, painful periods, pain with sex. And that broader bleeding history, nosebleeds, easy bruising, heavy bleeding after surgery or childbirth.
On physical exam, the bimanual exam checks uterus size, contour feeling for fibroids, look for signs of PCOS, obesity, hirsutism, acne, acanthosis, nigricans.
Check for thyroid signs, any visual field issues or galactorrhea, suggesting hyperprolactinemia, signs of bleeding disorders like petechia or bruising.
Okay, diagnostics. Pap test, definitely a pregnancy test.
Always rule out pregnancy first.
CBC for anemia, TSH for thyroid, maybe chlamydia gonorrhea testing, FSH, prolactin if indicated, coagulation panel.
Especially checking von Willebrand factor in teens with heavy bleeding since menarche. That's a classic scenario.
And endometrial biopsy, super important, first line of age 45 or older.
Yes, or younger if they have risk factors like unopposed estrogen exposure, if medical management failed, or if the AUB persists.
Then imaging pelvic ultrasound often first. Maybe a sonohysterogram for a better look inside the cavity.
Right, saline infusion, sonohysterography. And hysteroscopy allows direct visualization. Sometimes you can even treat things like polyps at the same time.
Treatment really depends on the cause, but for managing the bleeding itself, medical options like NSAIDs, tranexamic acid.
NSAIDs can help with pain and sometimes mild bleeding. Tranexamic acid is good for reducing heavy flow. Then hormonal options are key.
Combined estrogen progesterone pills, patch, ring. The LNG IUD is very effective.
Or progesterone-only methods, oral progestins, the DMPA shot, especially if estrogen is contraindicated. For really acute, heavy bleeding causing instability, a DNC might be needed emergently.
And longer-term structural fixes. Uterine artery embolization for fibroids if childbearing is done.
Yes, endometrial ablation is another option for some failed medical therapy, no future pregnancy desired. But they still need contraception, myomectomy if they want to preserve fertility.
And hysterectomy is the definitive treatment if other things fail or aren't suitable and childbearing is complete. A key exam point refresher. Normal cycle is 21-35 days, less than 80 millennial loss, last 7 days, and excessive bleeding is often defined by the patient's perception of impact on their life.
Good points. And some ward tips. Hemostasis during periods relies on platelet plugs and vasoconstriction. Always screen teens with heavy bleeding since menarche for von Willebrands. Postcoital bleeding needs evaluation for cervicitis or cancer. Classic adenomyosis patient. 40s, Paris, globular boggy uterus. Remember PCOS signs, oligomenorrhea, hyperandrogenism, obesity, polycystic ovaries on ultrasound. And that anovulation mechanism. Unopposed estrogen leads to proliferation, then disorganized shedding. A bleeding calendar can be really helpful for patients to track patterns.
Okay, let's shift to postmenopausal bleeding, PMB definition. Any bleeding after 12 straight months of no periods.
And the absolute rule, all postmenopausal bleeding needs evaluation, period.
Can't stress that enough. Most common cause.
Actually, endometrial or vulvovaginal atrophy, due to low estrogen after menopause, thin tissues, fragile, prone to microerosions, often called genitourinary syndrome of menopause, GSM now.
Makes sense. What else? Hormone therapy, obviously.
If they're on MHT, yes. Endometrial hyperplasia is a big concern. Think about sources of estrogen, maybe tumors, maybe exogenous estrogen without progesterone, maybe obesity-converting androgens.
Medications, too.
Yeah.
Anticoagulants to tamoxifen.
Tamoxifen can cause polyps, hyperplasia, even cancer. Some supplements, like soy phytoestrogens potentially. Benign endometrial polyps are common, but can sometimes hide malignancy. Infections like endometritis, and then cancer.
Endometrial cancer risk increases with age. Cervical cancer can present with bleeding, those estrogen-secreting ovarian tumors again, even rare uterine sarcomas.
So the history needs details. Onset, frequency, amount of bleeding, associated symptoms, weight loss, bowel bladder changes, fever, any trauma, relation to sex or pessary use, full medication supplement list, past medical surgical history, family history of cancers.
Physical exam. Find the source, look for lesions, discharge. Assess for atrophy pale, dry vaginal tissue, loss of rugae. Feel the uterus size, shape, mobility, tenderness. Check the adnexa for masses.
Diagnostics. Endometrial biopsy is usually the first step. Maybe STI testing or a wet mount. Pap test if needed, biopsy visible lesions. Transvaginal ultrasound is often done, looking at that endometrial stripe thickness.
The stripe thickness, less than 4 millimeter, might be reassuring if bleeding stops.
It might be, but persistent bleeding still needs investigation, usually biopsy. Hysteroscopy with DNC is valuable if there are intracavitary lesions, a thick stripe, high cancer risk if the biopsy wasn't adequate, or for persistent unexplained bleeding.
Treatment depends entirely on the cause. Atrophy, topical vaginal estrogen often works wonders.
Hyperplasia without atypia, often managed with progestins and close follow-up. But hyperplasia with atypia is treated basically like cancer, usually hysterectomy after ruling out invasive disease.
And if it is endometrial cancer,
Referral to gynecologic oncology is standard.
board tips for PMB. Assume cancer until proven otherwise 5–20% malignancy rate. Rule out GU/GI bleeding sources. Thickened stripe on US. Could be cancer, hyperplasia, fibroid, polyp. Stripe 4 or 5 millimeter generally warrants evaluation, and if giving MHT to someone with a uterus, they need progestin.
Absolutely.
Okay, pelvic pain. Let's start with chronic pelvic pain. CPP, non-cyclic pain, pelvic location. No 6 months, not pregnancy-related, often complex, multifactorial.
And often associated with central sensitization, where the nervous system becomes hypersensitive. The workup needs a super detailed history. Pain characteristics, timing, triggers, relieving factors, prior surgeries causing adhesions, full menstrual, GI, sexual history, dyspareunia, PID history, social history, stress, depression, abuse history, all relevant.
Physical exam needs to be thorough too. Abdominal exam, bimanual checking uterine size, mobility, tenderness, any cervical motion tenderness, CMT. Pelvic floor and muscle assessment. External genitalia, rectovaginal exam looking for uterosacral nodularity or fixed retroverted uterus suggesting endometriosis. Bladder check, speculum exam.
Labs can help narrow things down. CBC, pregnancy test, gonorrhea, chlamydia, urinalysis culture, maybe fecal occult blood, imaging. Pelvic ultrasound is often first line looking for cysts, masses, endometriomas, fibroids, adenomyosis.
CT or MRI sometimes needed.
CT MRI can give better definition, especially for suspected masses or malignancy. MRI is particularly good for adenomyosis and deep infiltrating endometriosis. Referrals might be needed GI for colonoscopy, urology for cystoscopy, maybe psychiatry.
Ward tip. Remember, non-gynecologic causes of CPP are common IBS, interstitial cystitis, IC, pelvic floor issues, depression. There's that mnemonic Lee-P2ing pain for CPP etiologies. And don't forget Mittelschmerz mid-cycle ovulation pain.
Right, that's usually self-limited. Now, acute pelvic pain, generally less than 3 months duration, often sudden onset, usually inflammatory, infectious, ischemic, or traumatic.
Potential causes are serious. Gynecologic things needing maybe surgery, ruptured ovarian cyst, adnexal torsion.
Tubovarian abscess PID, acute endometriosis flare.
Obstetric emergencies. Ectopic pregnancy, abortion complications. Critically important to rule those out.
And GIGU causes. Diverticulitis, appendicitis, IBDs, flares, UDPL nephritis, kidney stones. Lots to consider.
First priority, exclude life-threatening conditions. History focuses on onset, location, severity. The PQRST mnemonic helps. Physical exam looking for localized tenderness, CMT, adnexal masses, guarding, rebound.
Labs. Pregnancy test is non-negotiable in reproductive age. CBC, culture, chlamydia, gonorrhea testing. Pelvic ultrasound is key here, looking for cysts, torsion signs with Doppler, intrauterine versus ectopic pregnancy, fibroids, TOAs.
Treatment obviously depends on the cause. Maybe just NO-sides if it's simple. But surgery might be needed for an acute abdomen, unclear diagnosis, or life organ-threatening stuff. Laparoscopy is stable, laparotomy is unstable.
And a huge exam tip. New onset pain plus positive pregnancy test plus complex adnexal mass plus empty uterus on ultrasound until proven otherwise. You have to think ectopic first.
Got it. Okay, let's tackle endometriosis and adenomyosis. Endometriosis first. Endometrial glands and stroma outside the uterus. Severity of symptoms doesn't always match disease extent, right?
Correct. You can have minimal disease with severe pain or extensive disease with few symptoms. Lesions vary. Superficial peritoneal, ovarian cysts, endometriomas, deep infiltrating endometriosis.
Pretty common, 10–15% of reproductive age women, often diagnosed in 2030s. Major cause of chronic pelvic pain and infertility.
Affecting maybe a third to half of women with infertility. The issue is that this ectopic tissue responds to hormones.
Like ectopic periods.
Essentially, leading to bleeding, inflammation, scarring, adhesions. Common sites are ovaries, those chocolate cysts, peritoneum, ligaments. Less common, bowel, bladder, diaphragm, rarely, even lungs.
How does it get there? Theories include retrograde menstruation.
That's the most widely accepted, but probably not the whole story. Also, coelomic metaplasia, vascular lymphatic spread, immune issues maybe even spread during surgery. And there's a genetic link about a 7% risk if a first-degree relative has it.
Clinically, it's variable. Pelvic pain is classic, especially secondary dysmenorrhea. Pain starting before the period, lasting through maybe after. Pain with deep intercourse, dyspareunia. Painful bowel movements, dyschezia. Infertility, maybe an ovarian mass. Cyclic bowel bladder symptoms, but up to a third might have no symptoms.
On exam, maybe a fixed, tender, retroflexed uterus. Nodularity on the uterosacral ligaments. Palpable endometriomas.
Diagnosis. Gold standard is laparoscopy with biopsy showing glands, stroma, maybe hemosiderin.
But often, a clinical diagnosis based on symptoms, exam, and maybe imaging is enough to start treatment. The implants themselves can look different, classic powder burns, but also red, white, clear.
Clinical course varies. Can worsen over time, often improves during pregnancy, definitely linked to infertility through distorted anatomy and inflammation.
Treatment. Medical aims to suppress the implants, induce amenorrhea, relieve pain, but doesn't usually improve fertility itself. First line. NSAIDs, OCPs, cyclic or continuous.
GnRH agonists like leuprolide induce pseudomenopause.
Often need add-back therapy for side effects. Progestins are another mainstay, oral, injection, implant, LNG IUD. Danazol is older, androgenic, lots of side effects. Aromatase inhibitors like letrozole are sometimes used off-label for severe pain, usually with a progestin.
Surgical options. Conservative laparoscopy to remove implants, lease adhesions, preserve fertility.
Exactly.
Okay, now adenomyosis. Endometrial tissue inside the myometrium, the uterine muscle, leads to a symmetrically enlarged globular uterus.
Right. Affects maybe 30% of women, typically Paris women in their 40s, 50s, less common if never pregnant.
Yeah.
Can coexist with fibroids or endometriosis, common symptoms, chronic pelvic pain, that symmetrical uterine enlargement, dysmenorrhea, about 25%, and heavy menstrual bleeding, maybe 60%.
Diagnosis. TVUS is usually first line for enlarged uterus pain HMB. MRI can help differentiate from fibroids useful for surgical planning, but definitive diagnosis, only after hysterectomy on pathology.
Correct. Treatment targets symptoms. Medical options similar to endometriosis, sometimes GnRH agonists, NSAIDs, aromatase inhibitors, progestins, oral or LNG IUD. OCPs can help pain bleeding. Hysterectomy is definitive if childbearing is complete. Endometrial ablation, or UAE, might help some who are done with kids but want to avoid hysterectomy.
Comparing adeno versus endo. Adeno more common older, Paris women. Endo can be younger, nulliparous. Adeno tissue may be less hormone responsive. Adeno pain often more constant, less cyclical than endo typically is. And that exam finding for adeno. Enlarged, globular, maybe boggy uterus.
Good comparison points. So just to recap this deep dive, we've hit those key high-yield topics for the OBGYN shelf: hyperprolactinemia, AUB, reproductive age and postmenopausal, pelvic pain, acute and chronic, and endometriosis versus adenomyosis. We covered definitions, causes, diagnosis, treatment essentials.
And it really highlights the connections, doesn't it? Hyperprolactinemia causing AUB, endometriosis causing pain and infertility. It's all intertwined.
Absolutely. So we really encourage you, the listener, to review these concepts. Think about where you might need a bit more study based on your own learning style, and of course the NB&E blueprint for the exam.
And we'll leave you with a final thought to chew on. Considering this complex interplay of hormones and anatomy we've discussed today, how do you think future research, maybe new technologies, might refine how we diagnose and treat these conditions in OBGYN down the road?